Good evening, everybody, and welcome. We're going to give it just a few more minutes to make sure that everybody has enough time to log in. So we'll get started here shortly. Thanks again for attending. Good evening, everybody. We're going to give it a few more minutes just to make sure everyone has a chance to log on. If you are having any technical issues during the call, please contact Taylor. Her phone number is in the chat icon. Hello, everyone, and welcome. We're going to go ahead and get started. Thank you for taking some time out of your evening to join us today. My name is Erica Kurd. I'm with Boston Scientific. Today, we're going to hear from several providers about treatment options for chronic pain. We'll see what options may work best for your personal chronic pain, as well as suggest things to discuss at your next appointment. Throughout the presentation, you are muted. You are not on camera. You can use the chat feature located at the bottom of your screen. Please type in any questions that you may have. If you are having any technical issues, my coworker Taylor's phone number is also in that chat. You can call her or text her or type any questions in there, and we're happy to assist. But with that, we'll go ahead and get started. So first off, let's go ahead and meet our presenters. First, we have Dr. Christopher Malinky. He is a provider at Interventional Pain Management. Originally from Columbus, Ohio, he completed his medical degree from the Medical University of Ohio in 2002. Dr. Malinky has also completed a 4-year anesthesiology residency, followed by a pain medicine fellowship at Rush University Center in Chicago, one of the most prestigious fellowships in the country. Then we have Dr. Dennis Marcello, who is also a provider at Interventional Pain Management. He's originally from Ellicott City, Maryland. He received his medical degree from Aureus University. Dr. Marcello continued on to the University of Mississippi Medical Center, where he completed his anesthesiology residency and pain medicine fellowship. And then we have Dr. Roger Sung, who is a provider at Colorado Springs Orthopedic Group. He received his medical degree from UCLA School of Medicine in Los Angeles, California. He completed his residency in orthopedic surgery at UCLA School of Medicine and his fellowship in orthopedic spine surgery at Case Western Reserve University in Cleveland, Ohio. With that, I'll go ahead and pass it off to our providers to begin our presentation. Dr. Marcello, sorry to interrupt. You are muted. If you could unmute yourself.
Thanks, Erica. Sorry about that.
No worries. Thank you. Go ahead and start from the beginning.
Well, I just want to welcome everyone tonight who's joining our seminar. I just want to talk a little bit of our practice. We're Colorado Springs Interventional Pain Management, Dr. Christopher Malinky and myself. We have 3 PAs in our practice. We do med management, but we also do interventional pain procedures for patients who are suffering from chronic pain. But with that being said, I want to get started and start talking about pain. Well, in order to start talking about pain, I want to go over the definition of pain. So what is pain? Pain is the emotional and sensory unpleasantness that resembles or is associated with potential or actual tissue damage. So there's 2 types of pain we can classify: acute pain and chronic pain. In acute pain, it's usually less than 3 to 6 months. It occurs instant from an injury and just gets better over time when treated appropriately. Chronic pain is when it's 6 months or longer as defined. It can be difficult to treat despite treating the initial injury. And the chronic pain that is different from acute is the way it's described from patient to patient is very individualized basis. There's 2 types of causes of pain. There's mechanical pain, which most people have in their lifetime. It's usually caused by tissue damage, like for example, joint disease. Most of us, as we age, we get a form of arthritis, which is a type of mechanical pain. Typically, patients describe it as sharp, aching, and throbbing pain. And usually the treatment is done by your primary care provider, or also from a pain standpoint as a pain doc like Dr. Malinky and myself, or even to surgery, seeing an orthopedic surgeon like Dr. Sung, or even seeing other types of surgeons to correct this mechanical pain. Nerve pain is different than mechanical pain. It's actual damage to the nerve. This kind of sensation that patients experience is a little bit different than that sharp aching and throbbing pain. It's more burning. It's electrical shock. Some patients describe it as lightning bolt pain. And there's another type of character is that pins and needle sensation, like it's feels like ants are crawling. A medical term we call it is paresthesia. The treatment options vary greatly with patients who suffer from nerve pain versus mechanical pain. Of course, there's also medications, there's surgery that can be done, physical therapy, but there's also a behavioral standpoint with nerve pain. It reprograms our nervous system, and it affects us from an emotional standpoint. So there's also patients who need to see psychological counseling, that behavioral health modification or cognitive behavior therapy is one option. And these 2 that are bolded at the end of this PowerPoint slide, radiofrequency ablation and spinal cord stimulation. Both are treatment options through Boston Scientific, who we're collaborating tonight with this presentation. And we'll go more into that down the road here in tonight's talk. Next slide, please. So what we're really here for tonight is about chronic pain. And chronic pain, as I mentioned, it's 6 months or later. So it can be lifelong for a lot of our patients who we see every day at our pain management. And it's not just a physical type of sensation. As I mentioned in the definition of pain, it's also emotional. And that's really hits for most patients who suffer from chronic pain. It affects your hobbies. It affects your relationships. It affects your work. A lot of people with chronic pain end up not working, or they end up losing the relationships, or they lose hobbies, all that define them. And it's very common for a lot of patients to suffer from depression. In fact, about 40% of patients who suffer from chronic pain have a form of depression. So this psychological factor is a big component of patients who suffer from chronic pain. Next slide, please. So as I mentioned, the treatment pathway, all the way from seeing your primary care doctor, all the way to seeing a surgeon, an interventional pain provider, even a physical therapist, to seeing also a psychiatrist or psychologist. You usually start by seeing your primary care. They start prescriptions, they start the physical therapy, they do some initial workup, and after they start honing in what potential is causing your pain, then they move on to the next. They start sending you to, if it's something with your back, an orthopedic surgeon. They can see a pain management doctor as well. And then all the way to the right, these are potential options, which my other colleagues here in tonight's presentation are going to go more into. Next slide. I'd like to turn it over to Dr. Sung.
Well, thank you for allowing me to participate in this. I'm going to talk briefly on the surgical side of things. When we talk about surgery, we're trying to do a few things. We're trying to lessen back pain, eliminate nerve compression, and eliminate nerve pain, sometimes correct instability. But the overall goal is really to improve function. And when you look at this slide and you hear about discectomy or decompression or laminectomy or laminotomy, those are terms we use when we're talking about getting pressure off of a nerve. Some patients have a disc herniation, and when you have a disc herniation, sometimes that can compress the nerve and cause nerve type pain down the leg, or sciatica or radicular pain. When a patient fails conservative management and we get to surgery options, we oftentimes, for a disc herniation, will do what's called a microdiscectomy. That's a small surgery done under the microscope where we go in and we basically just shave away the portion of the disc that is outside of the normal disc space and is pushing against the nerve. It's an outpatient surgery, usually takes less than an hour. And the goal of that is to lessen nerve pain or pain that goes down the leg. Similarly, when you talk about a decompression, what you're talking about is a surgery to open up space for the nerves that are compressed. And we often see that in situations where patients have spinal stenosis, where there's overgrowth around the nerves, compression around the nerves, and pain down the legs. And sometimes these patients will even have that heavy, slow, sluggish feeling where your legs just don't seem like they're responsive anymore. And these types of surgery are small, minimally invasive surgeries to open up space for the nerves. When we talk about bigger surgeries, and still not large, sometimes when we're making space for the nerves, patients can have underlying instability or severe degeneration or arthritis in their spine. In those situations, sometimes in addition to making space for the nerves, we will also do what's called a fusion. And that's where we bring two of the vertebrae or bones together to become solid and become one, so that they no longer shift abnormally and they no longer compress the nerves. And oftentimes we'll do that in the neck and in the lower back. Along with that, oftentimes we will do what's called motion preservation or disc replacements rather than fusions. And we can do that in the neck and the lower back. Traditionally, we would do these through open incisions, and the outcomes for the right patient can be very good. In the last 10 years, I think a lot of surgeons have moved towards minimally invasive surgery or less invasive surgery. It's similar in concept to arthroscopic surgery or laparoscopic surgery or even robotic type surgery. And you get the same goals as open surgery, but it's done with less trauma to the tissues, less operating time, shorter hospital stays, and overall a faster recovery. And so all of these are options, but you have to really be careful that you have the right problem that is fixable with the right surgery. Oftentimes we see patients that have had surgery and their first response is, I had it and it didn't work. And you really just got to make sure that if you're going to have surgery to directly address a problem, you got to have a fixable problem. And so some things are fixable, and unfortunately, some things really aren't. And that's when we look at a lot of these other modalities to address pain. Next slide.
All right. I just wanted to say thanks for Boston for sponsoring and getting this organized for us. I'm going to talk about spinal cord stimulation as an option. And I think that it's important for people to realize, as Dr. Sung had just mentioned, that this is something that you can use to reduce pain, increase function, certainly reduce or eliminate pain medications or opioids. It's not fixing a problem per se, and I think is just important for patients to realize that from the beginning. I think the trade-off, though, is that it is less invasive than a lot of other surgeries or fusions in your back. So the actual procedures don't take that long. Usually it's done under just twilight or IV sedation, and it's often outpatient surgery. So you're not going through the same rehab or recovery that you would with other types of surgeries. Who can benefit from spinal cord stimulation? I think the main area that this works great for is nerve pain, which Dr. Marcello had talked about as that shooting, burning pain from nerve dysfunction. And that's something that's really difficult to control with pain medications, even opioids. Patients who have that, they know it'll take the edge off, it'll reduce it, it doesn't take it away. And oftentimes you'd almost have to sedate the patient before they really have complete pain control with oral meds. And you're also losing function then. As you go up on pain medications, and especially opioids, you start to run into other side effects. So it kind of defeats the purpose of what you're trying to do. Scoliosis or curvature of the spine can certainly cause nerve pain or chronic back pain. It can compress areas like Dr. Sung had mentioned in terms of nerves or the spinal canal. Something called post-laminectomy pain syndrome is really where people have had surgery, a laminectomy or a laminotomy, which is where part of the bone is removed to create more room from the narrowing, and they still continue to have either back or leg pain. And I think that a lot of people who have spine surgery do really great. Back pain is really tricky, whether you're treating it with injections or surgery, and sometimes people just have some of that left after surgery, and that's where I think spinal cord stimulation can come in and really provide relief, even if things have been improved mechanically and functionally, and there's still some back pain there. Radiculopathy, that is a medical term for sciatica. So that refers to nerve pain shooting down the legs, which is coming from the back, or going down the arms, which is coming from the neck. And spinal cord stimulation can treat both of those pretty well. Peripheral nerve pain, there's a lot of different causes for that. I think really the new indication for spinal cord stimulation in the last few years is peripheral neuropathies, specifically from diabetes. So that refers to pain typically in the hands or feet, stinging, burning in nature. And it's just sensory neuropathy, meaning it doesn't have anything to do with strength or movement, but it can produce numbness or real significant pain. And those patients, the most important thing is to control your blood sugar, obviously, so it doesn't get worse, but you can use medications for nerve pain like gabapentin or Lyrica. And for some patients that can provide relief, for others it does not, or the side effects just become so significant they can't tolerate it. And for those people, spinal cord stimulation is something that can also work quite well. CRPS or RSD refers to chronic regional pain syndrome, and I'm not going to go into that too much. Fortunately, it's a pretty rare problem, but it's nerve related, and it's something where you go through physical therapy, injections, other kinds of treatments. And when those don't work, spinal cord stimulation is proven to be very effective for that in those patients. Obviously, when you're talking about stimulation, it's not the first thing that you go to. So you definitely are going to try more conservative measures. And also you're looking at significant pain. So when the slide says, is your pain a 5 or higher? We don't necessarily ask the patient that and say, well, if it's not more than a 5, you can't qualify. I think people's pain fluctuates with activity and other kinds of things, but certainly if someone has pain that's 1 out of 10, spinal cord stimulation is just not something you need to talk about. But if it's moderate to severe and it's failed other conservative measures, then it's something I think reasonably that you can talk about. You're also looking at someone with chronic pain. So certainly you're thinking 6 months or longer. If someone has an injury and they've had pain for a month or two, spinal cord stimulation is not something that you're going to talk about for that particular patient, just like trying other injections, physical therapy, TENS units, other kinds of treatments, typically before you go to spinal cord stimulation. Okay, can we go to the next slide? All right, so we'll talk a little bit more about stimulation. Can we go to the next one? So spinal cord stimulation has been around for quite a while. It became more popular probably in the late 90s, early 2000s. It is FDA approved for people with back pain after surgery, CRPS, or peripheral neuropathy from diabetes. So insurances do cover that. Medicare does cover that. You do need to get it authorized, but if you have gone through conservative therapy and do have the right diagnoses, then it will be covered and will be approved, and they will pay for it. It is a non-drug therapy, so it's using low-level electrical stimulation to block pain impulses. There's not any kind of medication involved in that. Every few years, Boston Scientific or the other companies that make stimulators do come out with a new battery. They improve the programming, kind of like cell phones come out every few years. So over the last, I'd say, decade, there's been huge improvements in terms of how long the battery lasts, which now they're rechargeable and last 10 plus years. They're also MRI compatible, which in the past wasn't necessarily the case. And also the programming, or the way that they stimulate the nerves, becomes more sophisticated every year. And now there are hundreds of ways that they can combine the leads to stimulate to give people relief. And I think the other thing that translates to is there's different ways that we can make it feel for patients. So sometimes people like a light tingling sensation. Other people might like a pulsating, massaging feeling, like a TENS unit. You can also run it at very high frequencies where it's on and the patient doesn't feel anything. So certain patients prefer certain types of feelings. I think it also depends on what area of the body that you're trying to help, because in the back, for example, stimulation can feel better than it necessarily would in the legs or the arms. Okay, can we go on to the next? We have a video to play, so why don't we go ahead and play that, and then I can comment on it.
If chronic pain is keeping you from the everyday activities you love, you've probably tried a number of treatments to help manage it. Medications, nerve blocks, surgeries, and more. But because we feel pain and respond to treatments in different ways, these therapies may not always provide the long-term relief you're looking for. Spinal cord stimulation, or SCS, is a safe, drug-free, FDA-approved pain management therapy that's used by tens of thousands of people around the world and is clinically proven to help reduce chronic pain. And with Boston Scientific, this treatment can be tailored to your unique needs and preferences. Here's how SCS works. When you feel pain, in your back or leg, for instance, it's because nerves from that part of your body are sending pain signals through your spinal cord to your brain. SCS is designed to interrupt those pain signals using a small device called a stimulator, and thin insulated wires called leads. The stimulator generates mild electrical pulses that travel through the leads to nerves in your back, interrupting the pain signals before you sense them. SCS systems can be programmed to deliver different types of therapies. Some therapies replace your pain with a soothing, tingling sensation. Others use a kind of stimulation you don't feel at all. With Boston Scientific's SCS systems, you get to choose which of these therapies works best for you. You can even switch from one to another or use multiple therapies at the same time. The ability to use more than one therapy simultaneously is unique to Boston Scientific's SCS systems and has been clinically proven to provide greater relief from pain. Boston Scientific's WaveWriter Alpha SCS system includes a fast therapy option designed to provide rapid and profound relief you'll start to feel immediately. And it can be used during everyday activities, including while you're driving or sleeping. A key benefit of SCS therapy is that you can try it out with a temporary trial system to see if it works for you. Your doctor positions the leads and connects them to an external stimulator that's worn around your waist. Then, for the next few days, you'll be able to experience what SCS feels like as you walk, sit, sleep, and get back to enjoying life. And getting back your life is what SCS therapy is all about. A recent clinical study found that patients using Boston Scientific's SCS therapies reported a greater improvement in their ability to do everyday activities than patients reported in other studies using non-Boston Scientific SCS systems. And with WaveWriter Alpha, you get the comfort of knowing your SCS system provides access to full-body MRIs should you ever need one. Beyond your life-changing therapies, Boston Scientific also provides Cognita Care, a range of support tools and services you can use before, during, and after your procedure, so you can learn, connect, and thrive. Connect with one of our patient education specialists to answer any questions you may have, or chat with a volunteer patient ambassador about their personal experience finding lasting relief with SCS. And for additional support at your fingertips, download the My SCS app. Get on the path to personalized pain relief. Visit pain.com to find resources and learn more about safe, effective pain relief with Boston Scientific.
Okay. So I think just one of the things I wanted to highlight about that video is it mentioned doing a trial, which is essentially a practice run for the patient to see if this is something that they're going to want permanent. With surgery, obviously, you don't get that option. The way the trial is actually done is in office by Dr. Marcella or myself. It's like a spinal injection in that you lay on your stomach, you do it under X-ray. You have an IV where you have a little bit of twilight sedation, and there are 2 needles that go into the back, and that's how we place the leads. There's no major incisions. Once we put the leads into the back, we wake the patient up from the sedation and we start to stimulate their spinal cord. And at that moment, the patient will feel a tingling sensation, and we move the lead so that the patient feels the tingling over their painful areas. Once we finish that, we take the needles out, we resedate the patient. Usually we use a suture just to secure the leads to the skin and put a bandage on. And then the battery is either on the bandage or on a belt like it was in the video. And the trial can last up to a week, no longer than that. Typically, the patient will come back to the office once or twice to change their bandages. Sometimes they need to be reprogrammed with the Boston folks, sometimes not. And what we look for during that trial for success is a 50% reduction in pain or better is kind of the minimum cutoff. You also can look at functionality. Is the patient able to do activities of daily living a little bit easier? Is sleeping easier? All different kinds of things you look at, in addition to pain relief, to say this is going to be something that is going to improve your quality of life, which is what we're looking for. If the patient is on chronic pain medicine during the trial, if they're able to use a little bit less, then that's also a plus. Because it's only a week, usually you don't make huge changes with medicine, but using a little bit less is certainly fine. At the end of the trial, the leads are just pulled out of the skin. It takes maybe 2 minutes to do, whereas the trial procedure itself maybe takes 45 minutes. And then the patient decides based off those results if they want the permanent. And with the permanent implantation, Dr. Marcello, myself, or Dr. Sung can all do that. It's usually done in the hospital or surgery center. It's outpatient, so the patient goes home. There's an incision where the leads are placed, and then there's an incision where the battery is placed. And if you look at the figure here of the person on this slide, you can see the battery, and it is connected to the leads which go into the spine, and everything is underneath the skin for the permanent. The battery is about the size of a pacemaker, and it sits maybe 3-4 centimeters under the skin, so it's not that deep, and the incisions are a couple inches, so they're nothing huge or that significant. Roughly, historically, about 80-85% of the people that we've done trials on decide to have the permanent. And I think that's not because it works for everybody, but if you pick the right candidate, it can be really life-changing and really work well for them. And by the end of the trial, usually the patients are pretty clear if they want this permanent or not. Can we go on to the next slide? This just shows a couple different types of leads that are placed. On the left, the Infineon lead. Those are called percutaneous leads, and they're about the size of dental floss. Those are what are placed during the trial. So they are slid through the needle into the epidural space. They also can be used for the permanent implant. Dr. Sung could also place something called a paddle lead, which is the Cover Edge or Cover Edge X. And that is a little bit bigger and is actually secured to the bone, whereas the Infineon lead has an anchor placed on it, and that's secured to the connective tissue with stitches right on the outside of the spine. They both have advantages, and usually the doctors talk or decide what will work best for each particular patient, because it doesn't make that much of a difference for the patient in terms of their surgical experience. And it certainly doesn't make any difference about how effective it is during the permanent compared to the trial. Okay.
All right, so this slide kind of just recaps what Dr. Malinky talked about, how to find out if the SCS trial worked for you. The main thing, more what Dr. Malinky said, I just want to add is that there are some patients who think when they do the trial, they think if they go to implant, it might be a better result than the trial. We do want to stress that what you get during the trial is what you'll get when it's surgically implanted. So, we're always looking for a pain reduction, also getting some of your life back. By no means are we trying to say this is the answer for everyone's pain. As Dr. Malinky mentioned, it's not 100% of all patients will proceed to trial. There's different reasons why, but we want this trial period is like test driving a car. Make sure it's something you want to commit before you get it surgically implanted. So what you get in trial is what you'll get when it's permanent. Next slide, please. So during the trial period, as Dr. Malinky mentioned, we're stimulating certain regions of the body, and it's approved for the back and leg pain, typically nerve pain. And we usually give a vibration, what we call tingling or paresthesia sensation. So we make sure we're capturing the region of the pain. For example, patients who have back and leg pain, we want to make sure we're covering that during the trial. Some patients like that feeling. It's actually a smooth massage sensation. If you ever use a TENS unit, very similar, more profound. You can make it more intense because it's inside the body. Some patients don't want to feel anything. So the analogy we use is like a dog whistle. When we blow on the whistle, we don't hear it, but it's doing something because the dogs can hear it. So it's a perception that you want to know that it's working. You have the tingling, but for patients who don't need that positive feedback, you can just have the non-tingling, and it will help control and reduce the pain perception. without you feeling any positive feedback. And then some patients can have a mix. You can have both the paresthesia and non-paresthesia. And it's with the Boston rep or representative of the device company can target that tailored treatment option for you. Next slide, please. This is a research publication that was done around 2017. Just surveillance the patients after it's been implanted. So if you look at the bar graph on the center of the slide, they did a pain score out of 10, 8.6. And then after 2 years later of being on the spinal cord stimulator, their pain is still drastically reduced. So it's almost a 6-point reduction. And for those who can't read the slide, it went from an 8.6 to 2.98. And that's just across the patients in that study. In that 4-minute video that was played during Dr. Malinky's talk, that new program Boston has come out with called the FAST program, it's essentially immediate relief. So when we do these trials and the representative is activating the stimulator during the day 1 of the trial period, they're already having an immediate reduction in pain. Previous programming, they did not have that benefit. You had what we call a wash-in period, where it has the essentially soak in, and then usually a day or 2 later, you start getting some feedback of pain relief from the patient. But this is such a good game changer that the patient can already from day 1 reap the benefits of the spinal cord stimulator and feel that it's going to help them. So if you look at this bar graph on the far right, their baseline pain score of 8.4, as soon as we turn on the device with FAST, went down all the way to 1.3, so that bar all the way on the right. Before the FAST technology they had in their device, it was just a small reduction in pain from 8.4 to 6.5. So it was a drastic drop in pain. Next slide, please. So this one, it's overall the data after they compiled all the patients who have the Boston Scientific device. They're showing about 90% of patients who did the trial ended up proceeding with the implant device. And it has a pretty good positive feedback in those patients who got it implanted. They have a positive result down the road, even with the implant of 95% of patients would recommend it to others. And we've seen that in our practice of patients who had the stimulator referring their friends and family who suffer similar, and we can work them up and see if they're a candidate. 85% of patients in another study reported continued pain relief of 50% or more in 2 years after the procedure. And that's kind of the previous slide I'd mentioned prior. And I think next slide will be Erica to talk about their application with their device.
Thanks, Dr. Marcello. So yes, as part of a partnership with patients, providers, Boston Scientific has an app. You can download it on an Apple or an Android phone. There's a lot of great resources on there for before the trial, during the trial, after the implant. There are videos, testimonials, resources of patients that have already gone through a trial, so you can get firsthand experience. During your actual trial, it's treated as a digital pain journal. So we get to hear directly from you, the patient, to see how you're doing, logging your activity, your mood, your pain levels, adding in comments, which also can help support insurance authorizations. You can, after the implant, it has your digital implant card on there. And just, again, more resources on how to use your remote control, how to use the charger, things like that. So it's a valuable tool. You can use the QR code on your screen now if you'd like to scan it to download it to your phone to start exploring on your own. Next slide. You can always visit pain.com, which again has a lot of resources on it. If you were already implanted with a stimulator, it has an MRI finder to find resources on having an MRI with your device. It can lead you to a series of pain management providers in your area that are familiar with spinal cord stimulators. More information about the app, speaking to a patient ambassador, so getting to hear firsthand experience about someone who has gone through a stimulator. So a lot of different resources. Slide. And now I'm going to go ahead and pass it off to Chris Booth. Chris is a patient who has a unique pain journey and was going to share it with the group. He has been implanted with a spinal cord stimulator. So I'm going to go pass it off to him and let him walk us through his story and his journey with pain and how he's doing today.
Thank you, Erica. Can you guys hear me okay?
We can hear you great. Thanks, Chris.
All right, perfect. Well, first, I just want to thank everybody for the opportunity this evening to share that journey. I think back on this road, and it's been a long road, but I think back to some of the important parts, I think, along the journey of what was important to me and helped me. And this was part of it. Being able to hear from somebody else that's kind of walked a few miles in those shoes really made a difference to me. So again, thank you for this opportunity to be able to share it with the people on tonight. So my name is Chris Booth, and a little of my background: I have worked in healthcare now for 26 years. I've been a nurse for 16 of those years, and I share all that to say my journey started on a day that was just like probably hundreds of days before that. You know, you wake up real early to go to the hospital in the morning, and that's what I did. And I got out on the interstate, and a gentleman had actually been driving an 18-wheeler all night long and fell asleep and kind of played monster truck, I guess you could say, with my car. I was just about all that was left of my car. So ironically, you know, I'm headed to the hospital to try to help somebody that day, and I end up going to a completely different hospital to be the person that needed some help. And some of you guys may relate to that. Life can change in an instant, and boy, did it change. I spent quite a while in the hospital and underwent several procedures to kind of piece me back together, I guess you could say. I kind of felt like the Scarecrow in the Wizard of Oz when they're putting them all back together. But I went from the hospital to my house, and that's where I stayed for quite a while. And that was difficult, you know, to be very honest. That was a tough time. That was a dark time. Just a young guy trying to provide for my family. I had only been married a couple of years at that point, and our daughter had just turned a year old. So it was tough. It was very difficult for me as a husband and a father to not even be able to hold my baby girl at that point. I couldn't even pick her up and hold her. I can remember days where I would just lay in bed, and I would watch my wife and our daughter leave to go to work and to school, and just see that door close. And I would lay there all day and wait for the door to open and for them to come home. So a tough time. I went from bed rest to wheelchair to a walker. Actually walked on a cane for about 2.5 years. My pain is in my lower back and kind of wraps around towards my groin and then runs down my leg a little bit. And, you know, the doctors are always asking you, you know, what number is your pain? If 0 is no pain and 10 is the worst you can imagine, what number would you give it? And my pain stayed at about a 7, 8, 9. So again, if you guys can relate, just a severe level of pain, that kind of pain makes it where it's difficult to focus or concentrate on other things. And it's really hard to even be a part of what's going on around you. And I didn't feel like I was at that point. So even after those procedures, kind of putting me back together, I was still left with that pain. And so I did get involved with pain management, trying to find some solution. What do we do from here? And goodness, what did we not try? We tried a little bit of everything: physical therapy and water therapy, TENS unit, medications. At one point, I was taking 16 different medicines. You know, not all pain medicines, but muscle relaxers and just kind of all the things that go with it. And I tried some different injections, and I want to say that the injections actually helped a little bit. They just didn't last very long for me. And at some point, my doctor came to me and said, you know, Chris, I don't know if you've ever heard of this company, Boston Scientific, but they actually make a device that's for your type of pain if it's something you're interested in trying. And I look back on it now and I kind of laugh. because I ran from it. I said, absolutely not. I don't want anything to do with this thing. I think I had just already tried so many things that had not helped me. I didn't want to do anything else. And I went back to physical therapy probably for another 6 months or so. And it was really at a follow-up visit that they brought it back up and said, Chris, this is still an option for you on the table if it's something you're interested in. And I think me personally, I was just in a little better place to kind of hear them out, see what it was that they had to say about it. And so I read the material and watched the little DVD and asked a whole bunch of questions. And then I went home and talked to my wife about it and my family and, did some praying about it. And the answer I came up with is I wanted to see about this trial, kind of like what we're talking about tonight, because I looked at it like if the trial helps, I might can move forward with it. If it doesn't, I'm just kind of checking it off a list of a pretty long list of things that I've tried that hadn't really worked. So at the end of the day, I didn't really know how much faith to put in all of it, but I kind of looked at it like, if it doesn't work, I'm really no worse off than I am right now. So kind of what have I got to lose? I might as well try it and see if it'll work. And so I did decide to move forward with the trial. And guys, I can't tell you how amazing my trial experience was. It was like night and day. That 7, 8, 9 pain that I described went down to about a 1, 2, 3 kind of pain. So again, not a 0, but to go from a 7, 8, 9 down to a 1, 2, 3, I felt like I had a whole new lease on life, a whole second chance here. I did see my activity level increase a little bit during the trial. And another big thing for me is after the wreck, I had a really difficult time getting comfortable trying to go to sleep. I may fall asleep and then wake up 5 or 10 minutes later with a spasm or a cramp or something running down my leg. And I noticed even during the trial experience, I was able to get a good restful night of sleep. So that was huge for me. But finished up the trial experience, went and met my doctor back in the office, and they said, Chris, do you want this relief all the time? Is this something you want to go forward with? And I laugh at that too. I said, are you kidding? I don't even want to stop the trial. Let's keep doing this. It was such a great experience. But I did decide to move forward with the next steps to have it all the time. And I have now had my stimulator for almost 10 years. I've had my stimulator almost 10 years. I still use it every day. Still helps me every day. It was definitely the best decision for me. I never tell anybody, oh, you need to get a stimulator because I have one. I just think I am a good example of what it can do for somebody. So when I have this opportunity to share my story or, people ask for advice about it, that's what I always tell them is, have that conversation, ask those questions, see if this is something that may be right for you, because if it is, it really could change your life. But that's my story. That's my journey with all of it. And I really appreciate that opportunity to be able to share it with you guys this evening.
Thank you so much, Krish. Appreciate you sharing your story with us and taking the time out of your evening. Next, we're going to go ahead and open it up to some questions. All right, so first question I have is actually for Dr. Sung. You had mentioned that you deal with compressed nerves. How are you able to tell if somebody's nerves are compressed? What are the steps you typically take, perhaps at a consultation appointment?
Sure. I think there's two main things. One, you got to meet with someone, you got to talk with them, you got to listen as they tell their story about their pain to make sure they are talking about nerve pain and what you see on exam, how they move, how they describe the pain, that we are talking about nerve pain. And then the second is imaging. I like to get x-rays because you can see how a patient moves. So we get x-rays of a patient standing, and we get them bending forward and backwards to see how their spine moves. And that shows on a general picture of what a patient's spine looks like. And then specifically to the nerves, we get MRIs. MRIs show nerve compression in great detail. They can show disc herniations, spinal stenosis, degeneration in the discs. And that's how we can usually determine that a patient's pain is coming from nerve compression.
Great. Thank you so much, Dr. Sung. Next question would be good for Dr. Marcello. So Dr. Marcello, how do you ensure that leads stay where they are? So after they're implanted or maybe even during the trial, I know we touched on that briefly, but how do you make sure those leads stay where they need to be? Are there any certain precautions that are done during the procedure, as well as maybe any recommendations after the procedure?
That's a good question. So during the trial, as Dr. Malinky had showed in one of those slides, is there's type of leads that we place. One is the percutaneous lead, as interventional pain doctors, myself and Dr. Malinky do. But the other one is the paddle, which is what a spine surgeon like Dr. Sung places. Well, during the trial period, the percutaneous leads are placed. They're placed under X-ray guidance, and we're able to use a needle as a cannula to place it inside the spine in the epidural space. As Dr. Malinky had mentioned, is we just put a small little suture on each lead at the skin, which just reduces the chances of it moving during the trial, but nevertheless it can move. So during the trial period, all patients are cautioned not to do any severe bending, lifting, or twisting. I always tell patients, when you're tying a shoe, don't bend down, bring the shoe up to you when you're sitting down to tie it, because any great flexion or extension of the spine can shift those leads, and you will not get the appropriate coverage of your pain. Now, moving forward to the implant, as there's two different types, and we take in big consideration of which way the patient proceed. With the percutaneous lead placement, those straight wires that were on the slide all the way to the left on the one Dr. Malinky talked about earlier, that's placed by the interventional pain doctors, and that's just done under twilight sedation. And we wake up the patient in the middle of the case to make sure we're capturing their pain. After that's surgically implanted, we don't want the patient doing any significant bending, lifting, or twisting for about, and this depends for patients, but from 30 to 60 days, so 1 or 2 months, we want some scar tissue to form around the leads so it helps reduce the migration inside the spine. But we still throw a small anchor at the connective tissues above the spine, so it's not in the spine, whereas Dr. Sung can go more in this in detail if needed, is the paddle leads, it's fixed inside the spine, and that really greatly reduces the chances of migration. So when patients are going through a trial, if they're leads are already moving with minimal movement, and during the trial, I'll send my patients to Dr. Sung, the spine surgeon, for the paddle placement. If also the spine is significantly degenerative, if they had multiple back surgeries, or if it was a very difficult technique placing during the trial, those are other reasons to refer the patient to Dr. Sung to get the paddle placed. And it would be easier compared to an interventional pain doctor such as myself or Dr. Malinky to place. That's a good question.
Thank you so much, Dr. Marcello. Next question I have is for Chris. So Chris, how often are you meeting with your rep? How long does a typical reprogramming take? What is the care of the device since you've been implanted, essentially?
Yeah, that's a great question, because I kind of wondered the same thing too. I would say I kind of met with my team a little more towards the beginning. I think I probably just had more questions about it, and there, you have follow-up visits and that kind of thing there towards the beginning, and they were able to offer some additional programs or kind of change and tweak things in there just to make it more personalized for me. After that initial period, I would say, I think I met with them maybe about 6 months later, and then goodness, I may get reprogrammed about maybe once a year or so at this point. It's not very often at all, but I do know that it's a great support team. There's people that I can call whenever I have a question or anything like that. I've had great resources with that. And how long does it last? Goodness. Maybe 15, 20 minutes. It's not very long. It's how quick can I answer the questions, because they can put it in there really quick.
Great. Thank you so much, Chris. Appreciate that. Last question we have for Dr. Marcello. Can you explain the difference between a TENS unit and SCS. So I'm assuming you're also just, discussing the tingling sensation. So how does that differ? What is the difference between the two?
Sure. So the two main differences between a TENS unit and SCS is, of course, the amount of technology, but from a easy standpoint is the SCS is inside the body versus the TENS unit is outside. And the TENS unit is essentially a one-trick pony. It only sends one wavelength, and it helps try to focus on that vibration or that paresthesia sensation and not on the pain. So easiest analogy is if you bump your elbow or your funny bone and you rub it, you focus on the rub and not the actual pain from the elbow, because you hit a peripheral nerve right there in the elbow and you feel that sensation down to the fingertips. That's essentially the TENS unit. Whereas the spinal cord stimulator, it's a more elaborate and intricate type of electrical signal, and it can produce it can yield different effects. There's multiple programs. As I mentioned, there's the paresthesia where you can feel that tingling, or no paresthesia. And in each of those two types of nerve modulation, there's different intensities, there's different strengths that they can modulate to make sure you capture your pain in a more effective way than the one-trick pony, so to speak. Also the spinal cord stimulator is you can have it oscillate different technology instead of just one program throughout the day.
Great, thank you, Dr. Marcello. Another question here for Dr. Sung. I'll give this one Dr. Sung. So this person asks, are you able to do everything normally with an SCS implant? Are you able to run, work out, bend over? Are there any other restrictions you put on patients, specific healing period of time, or are there any activity restraints?
When we first put it in, we do put restrictions for the same issues that Dr. Marcello mentioned. We want the paddle to scar down to the spinal cord, so it's less likely to move. After, I usually restrict activities for 6 weeks, but in the long run, I tell the patient to listen to their body and use pain as a guide, but I don't like to put permanent restrictions that because you have a stimulator, you can't do this or that. It really depends on where you're comfortable and what your body tolerates.
Thank you, Dr. Sung. Dr. Marcello, another one for you. Is this effective just for low back and leg pain, or can it also be used from a cervical standpoint?
So the spinal cord stimulator, it's FDA approved for back and leg pain. If any patients have areas of other parts of the body, certainly make an appointment with our office we can discuss further about this. With our contact info, you can certainly get it from any of the Boston representatives here tonight. And also, you can also get the information to Dr. Sung's office as well. And we will be happy to direct you to the appropriate answer.
Perfect. Thank you, Dr. Marcello. And you can stay unmuted because I have one more for you. So there's some concern that if you're masking pain, so if you're running a stimulator and you're masking pain to a specific area, should you be concerned that running the device will overall increase damage to an area? Does running it make that pain area worse?
Yeah, so using a spinal cord stimulator device to target regions of the back or leg pain, or knee pain, foot pain, it's covering a certain type of pain already that you have chronically. So I get asked this all the time: if a patient gets in a motor vehicle accident and they break their foot where it's supposed to be covering their foot, will they feel it? Yes, you will certainly feel it. It's a different type of nerve fibers. There's multiple nerve fibers within the nervous system, and in a breakdown within the nervous system, there is different nerve fibers within the central nervous system, where it houses the spinal cord and the brain. So that acute traumatic pain is gonna be a different nerve fiber, a much larger nerve fiber, and fire just as it would if you never had a spinal cord stimulator. Patients with chronic pain, and we've evaluated it, as Dr. Sung had mentioned, you've had surgery, you got the hernia disc corrected, and the nerve is freed, but they still have that nerve pain. This could be, long-term nerve damage. So structurally, if you have been corrected, the initial underlying issue has been fixed. If they did the laminectomy, they removed the bone to free up the space or open up the real estate, so to speak. At least it's structurally corrected, but the long-term nerve damage is there. So in terms of causing more damage to the injured area, it's unlikely for that to happen. Certainly there's other medical conditions that indicated for spinal cord stimulation. As Dr. Malinky had mentioned, diabetic peripheral neuropathy. Well, for example, patients who have diabetes and they're uncontrolled, the spinal cord stimulator is not going to be the one-stop shop to stop that nerve pain. It's also, we had to put the responsibility to the patient to also control their blood sugars. If you still just let it go rampant and not control that diabetic peripheral neuropathy will get worse to a point where the spinal cord stimulation won't help that pain. So in essence, you can cause more damage to that area. Good question.
Thank you, Dr. Marcello. Last question here we have is for Chris. So are you able to go through TSA, through airports, security like that, or any other specific precautions you need to take with your device?
Oh, let me unmute. Yes, actually, I enjoy traveling. I think they're very familiar at this point with people that have implanted stuff, knees and hips and all kinds of things. Most of the time, I just say I have an implanted device, or sometimes I even say I have a spinal cord stimulator, and they're already familiar with it. Other times that they're just not as familiar, I do have a card. I have a little card that says you have a medical device, that says what kind it is on there, and I just show that to them. And then also the app on my phone has it on there digitally where I can just show it to them. So I haven't had any difficulty at all going through any kind of screening with any of that.
Wonderful. Thanks so much, Chris. Well, again, I want to thank everybody, the providers, the patients who attended this evening. Thank you for taking some time to learn about more chronic pain solutions. Next up, we're just going to have a quick poll, if you wouldn't mind answering a few questions for us, just so we can follow up with everyone accordingly. Again, appreciate all of your time. Hope you have a wonderful rest of your evening.